So in the time allotted, it is quite difficult to speak about the ethics of this current trial and the difficulties that we have gone through to be able to execute this study. The initial period, and I think the pertinent question that most of the audience would like to probably hear about is the Sisonke boost. So I will be covering some of that. At the beginning of Sisonke, access to vaccine in South Africa had been delayed. And so the critical heroes of healthcare, our healthcare workers, did not have access to vaccine. And the Sisonke study team approached the COVPN and JNJ to access 500,000 doses of vaccine for healthcare workers. We were given a window between 17th of February and 17th of May, during which we executed the Sisonke phase 3B study. The date of 17th of May was the beginning of the national rollout and provided then an opportunity for first people over 60 and healthcare workers to gain access to vaccine. At the end of the 17th of May period, in fact, there was some hangover because rural vaccination continued into the balance of May, and our sub-studies continued into June. But overall, we ended up with 122 sites across the country administering over 477,000 vaccine doses to healthcare workers. I will show some of the efficacy just for results, vaccine effectiveness results, but the real question was, this was a single dose of vaccine. And so the real effectiveness and scientific rationale question needs to be addressed to consider the ethics questions as to whether a second dose of J&J vaccine should be provided. The important component of boosting the first J&J vaccine, while it was effective, it appears that vaccine effectiveness does wane over time. There may also, from a single dose, be reduced effectiveness for the Delta variant over time. And we need to also consider which, in a public health setting where we have only achieved around 32 to 37% of the population having a vaccination, we need to consider whether there are specific subpopulations that need an additional dose of J&J. We need to consider that at this time only Pfizer 2-dose regimens and J&J single-dose regimen is the national policy. The question of benefit versus harm, we certainly know or ask the question as to whether these are safe and immunogenic, and will, in fact, the additional dose reduce the incidence of COVID, hospitalization, and mortality, and then overall, the vaccine effectiveness, does a boost dose add to the vaccine effectiveness of Delta variant? Overarching in our constitution is, in fact, a right to decide on whether is a right to decide on your own healthcare. And the principles in the constitution, however, need to be considered as whether these are individual rights are above and beyond the public health rights, and therefore whether it is reasonable and justifiable to contemplate in settings of significant risk whether in fact a COVID vaccination policy could shift towards mandatory vaccination. I put this up here because an equal constitutional right is the right to consent in research, voluntary participation, and the right to withdraw from research. The SAMRC slide that I've used here are moving towards a mandatory vaccination policy, but my own organization, Right to Care, implemented a mandatory vaccination policy, taking into account accommodation for those who have a medical reason to not vaccinate, and taking into account accommodation as far as possible for those who, for religious reasons, do not wish to vaccinate. However, the principle of risk amongst healthcare workers is significantly high, and therefore we are anticipating shifting towards more and more mandatory vaccination policies amongst healthcare workers. So the overall aim of the Sisonke Boost protocol is to go back to all of those healthcare workers that consented for the first Sisonke study and offer a second vaccination boost. It is an open label single arm study, so everyone will receive vaccine. It is the outcome will be measured in comparison with vaccinated populations pre-boost and unvaccinated populations in South Africa. The background to this is that the Ensemble 1 study, which was a single dose of vaccine, did in fact demonstrate a 66% overall effectiveness with a higher benefit for those who were in fact for severe disease. The cutoff date or the data was taken from 28 days post-vaccination. And so timing becomes an ethics question as well. We're in a low incidence period at this time. And do we, in fact, should we be waiting for government policy and the VMAC to be able to implement the shift in policy in the country? Or should our healthcare workers be offered a second dose as soon as possible? If we look then at the second phase 3 clinical trial that informs our decision to go ahead with the second dose of J&J, it was the Ensemble 2 study, which was a randomized study of a single dose versus a booster dose. And basically, on the right was the Ensemble 1 study, which was a single dose of vaccine, demonstrating an overall effectiveness for COVID infection of 53%. I think these are the control arm and the Ensemble 1 study combined, with a reduction in severe or critical COVID infection of 75%. Whereas on the left is the 2-dose strategy, demonstrating significantly increased benefit from a second dose of vaccine. If we look at the 477,000 participants, the number here has changed a little on the front of the slide versus the publication. This is the addition of some back capture data. We demonstrated an overall reduction in severe disease and death, which really represents significant benefit from the first dose of vaccine despite a Delta pandemic. Here it's described in pictorial format for hospital admissions, really showing a marked reduction in hospitalization, in ICU admission. The confidential do not share does not apply any longer, as in fact this data is now published, and in a marked reduction in death between vaccinated and unvaccinated healthcare workers. This Sisonke cohort probably represents the largest, or in fact, I know it represents the largest cohort of J&J vaccine implemented within a consented study cohort. What's really important about the ethical environment is that regulatory approval for this study is complex. At the National and Provincial Departments of Health, we needed to assess feasibility, resource allocation, staffing. The J&J vaccine that is being donated to the Sisonke Boost protocol is being donated due to, as J&J have not submitted dossiers for regulatory approval in South Africa yet for the boosting of their single dose regimen. On the right, in the light blue block, we see that in fact this translates to a vast number of public sector sites and a substantive number in the private sector that also need to address out-of-hospital healthcare workers. With applications to SAHPRA as the drug regulator and the institutional review boards, the entire effort has become extremely complex. And indeed, this was the same complexity that we had in Sisonke 1. The only way to establish voluntary participation at this size and scale is to, in fact, do consent through an e-consent portal under the EVDS systems. Those will be back in place. Many participants in this conference will recall, in fact, that they were asked to e-consent. The access to data to actually monitor the outcomes of this huge undertaking is part of the consent. And we tie up using ID numbers and names and dates of birth. We tie up a number of data systems that include the COVID-19 diagnostic piece under the NHLS, hospitalization under DATCOV, and in the private sector under the medical schemes, and then mortality, both reported mortality as well as a check with the Home Affairs database under the leadership of Debbie Bradshaw. These are the ethics committees. These are the different CRSs. That complexity has been underway over the last 10 days. We're hoping to, in fact, have all the ethics committees and SAHPRA aligned by tomorrow morning to begin the release of informed consent SMSs inviting participants to the study on Tuesday morning. This was the remarkable timeline from study protocol design to inception that we undertook in the February period. Interesting enough, the boost protocol has created more controversy and questions than the original protocol generated. However, we appear to be on track for a launch on Tuesday. The pharmacy elements have changed, so this is an ethics and study consideration as well. In the beginning, we were working with unregistered product, and we had to run this with specific pharmacy study teams. The current protocol indeed will be run more as a national rollout and with commercial stock, and therefore the preparation of vaccine, this component has fallen away. Each step of the way needs to continue, so significant consideration for the ethics and the lack of coercion, so participation has to be voluntary. The right to withdraw is in place, and indeed healthcare workers who choose not to take part in the Sisonke boost could in fact consider to wait for an alternate boost option that may become available in the future. The key element of our analysis, and again, this is an ethics consideration, so we're doing this as a phase 3B study, but an ethics consideration to do this as a study is that we have really gone through our 3 waves of infection, and we stand just before a potential 4th wave. I believe that in fact our 4th wave is likely to be less significant than our 3rd wave was. However, the timing of vaccination during this low period is critical, and we part of the execution of the study is to in fact be finished by the middle of December, ahead of the anticipated 4th wave. In terms of why a study, or if we're doing a study, what are ethical considerations about collecting data? And so on the left of this graph, everyone receives the consent SMSs. In the middle of the graph, all adverse events can be reported. On the right of the graph is in this column here is the integration with NHLS and DATCOV databases, as well as the private databases that enable us to report the safety and vaccine effectiveness across the system. This data will, and in fact we appeal to the scientific community and the participants to realize that not only will there be benefit from the second dose of J&J, but there will also be contribution to science as a participant of Sisonke. There are now around 4.5 million doses of J&J that have been distributed in South Africa. This study will inform the national program, the national policy on whether in fact second dose vaccinations with J&J should be undertaken. The current emphasis of the National Department of Health is to rather focus on reaching the first dose coverage than to go back and begin the process of J&J's second dose. My acknowledgements are to the HVTN leadership and Johnson & Johnson, without whom none of this would have been possible. Funding for Sisonke does come from Treasury, National Department of Health, and the NAT joints. BioVac and BioCare have worked with us in great detail with the vaccine distribution during Sisonke 1. These are some of the other funders. This effort has been colossal in the number of people that have been involved, particularly on the safety team, protocol safety review team. Professor Jacobson, who's on this call, and others have helped us define the serious adverse events. And then the incredible research site leadership, not least of whom these sites, we would not have been able to execute this at a phase 3B research level without these teams. And then all the vaccinators throughout the country and staff who have helped us execute the program. Barry, I'm going to pause there to see, or Mervyn, sorry, to see if there are any questions. Thank you very much.
Thank you, Ian, number one, for your excellent work, and also for this excellent overview, very eloquently shared. There are indeed several questions, and they all pertain essentially to what is going on in terms of the discussion amongst a variety of healthcare workers. And perhaps I could kick off with some of the ethical issues, because they interlink with several of the questions that have been asked. So essentially, with respect to the Sisonke Boost study and the ethics thereof, is it ethical at this point in time to be offering this as the sole choice for healthcare workers, particularly those who are at high risk, many of whom are now going on 9 months down the line from their initial booster, when there is data out there suggesting that other alternatives might result in a better response? So that would be number one. And number two, for those who choose to remain anonymous regarding the fact that they may or may not have had a so-called unofficial booster, how reliable will your data be if that is not shared at the time that people do, in fact, take a J&J boost? And this links up with several of the questions effectively that have been asked. So perhaps let's run with those two initially, Ian. I know they difficult entities trying to address, but I think they're absolutely relevant, because this is the discussion that's going on with healthcare workers at the moment.
So Mervyn, I chose not to address this question right up front, because indeed we have a Sisonke study team view on this, and then there's a national policy view on this, for which we are not responsible. The Sisonke study team view is that we have data from Ensemble 1 and 2 that show a significant difference between Ensemble 2, a significant benefit. There's also a benefit to, or a demonstration that vaccination more than 2 months, after the first dose is an appropriate time to give the second dose, with a 9 to 12-fold increase in antibody responses. The studies are large, the safety is established. The adverse event rates were very low. The heterologous boosting is purported, but in very small studies, with probably a benefit of adeno vaccine such as AstraZeneca or J&J into a Pfizer vaccine, but the studies are small. They do demonstrate slightly higher increases in antibody levels and CTL responses than a J&J into a J&J. However, they are all not large enough to actually understand the safety of doing that sequence of vaccinations. There will be 2 studies in South Africa going into that will measure. So WRHI will be hosting a prospective study of J&J into Pfizer. They have gone to SAPRA for approval. At this time, neither a booster dose of Pfizer nor a booster dose of J&J is approved by SAPRA in country, and therefore the only way that we could do this was to do a phase 3B study. We believe that in fact we will generate the data that will inform the rest of public health. The other element that I think people need to realize is that going forward, we have a vastly higher quantity of J&J vaccine coming to South Africa than Pfizer. And therefore, there are public health considerations that we need to address. So I think healthcare workers who wish to wait to access an alternative boosting dose have the option of doing so. From a Sisonke study team, we have essentially put in place what our frame of responsibility is, what we can do today. What we'll be able to do in 2 months' time may look different, but what we can do today is, and rapidly ahead of the 4th wave, is to offer a second dose of J&J. So the science, I think, supports giving a second dose. The safety supports giving a second dose, and therefore we have made our ethics application.
Ian, can I also just say a few seconds about the J&J booster? That we have a study running now. We finally got ethics approval for anyone that's had a J&J booster.
Pfizer booster, Barry.
Sorry, a Pfizer booster. Everyone that had a Pfizer booster, so-called illicitly, we are doing anonymous or open study to people to get the antibody levels. They must just contact us. We're doing a study where we will measure your antibody levels for free, and we're asking people if you've had a Pfizer booster, don't go for the J&J booster because it'll skew our data. But we have it available, and they can contact me.
Yeah. So there's a more important reason that so as clinicians and study team participants, we have at length discussed the safety of a sequence of J&J into Pfizer and back to J&J. And at this time, there really is no data, but we actually would be concerned that there would be an increased risk of side effects of adverse events. And so we strongly do not recommend that if you've had a Pfizer vaccine after your J&J, that you come back to have a J&J. In fact, it's an exclusion criterion, and during the consent process, you will be asked if you've had an additional dose of vaccine outside of Sisonke, and if so, you would be excluded from the Sisonke study. The So that's critical, right? And I think that Sisonke understands that people have done, what they've done, and we're not trying to be policing this. Indeed, in terms of skewing the data on a population of 477,000, we would be surprised if the number of people who've had access to Pfizer outside of the regulated EBDS data collection, that number will be significant. We are anticipating that only 60 to 70% of healthcare workers will take up this opportunity, but that's still a massive number of participants at 300 to 350,000.
Yeah. On a personal note, Merv, can I just say, I just want to just thank Ian, Glenda, and LGB. I mean, you have saved more healthcare workers' lives than that is possible. It's an amazing job that you did for Sisonke, and I think we all owe you a huge debt of gratitude.
And we've got lots of good. We've made lots of good friends and have lots of colleagues that have assisted, including our Barry, who worked on our protocol safety team. He taught us everything. When coagulation became a problem overnight, I've learned more about the coagulation pathways than I did for my FCP. Thanks, Barry.
Pleasure. I think we're running.
Yeah. I don't know if there were any other questions.
I think in general, you've answered effectively all of them. So it really pertained to the ethics, to the choice of people, and to who would be eligible to enter or not. And I think that covers the spectrum. So thanks very much, Ian. And I can only second Barry's sentiments. Well done, and thank you.
Thanks to the organizers again. And thanks to everyone for listening. We hope to see you on Tuesday for your doses. Thanks.
I'd just like to now hand over to AJ, who's going to close the meeting. Thanks very much, AJ.
Well, thank you, Barry, Mr. President, and all of those who have been involved in this year's South African Society on Thrombosis and Hemostasis meeting. It's been a splendid meeting. We have been privileged to have received presentations from a distinguished group of colleagues who have covered a wide spectrum of questions pertaining to cardiovascular disease, to thrombosis, to anticoagulation, and of course, to COVID, bleeding, ethics. As always, a truly magnificent and broad-ranging program, which is intellectually stimulating, but also clinically pertinent and very powerful in terms of the experiences that we're all have had and continue to have during this global pandemic. So thank you to Barry and the organizing committee for having delivered us such a splendid program. Of course, thank you to the faculty who, as always, have prepared to a spectacularly high level, really outstanding presentations at the cutting edge, but always clear and insightful and therefore meaningful to the audience. Thank you, I think, to the super large audience on this occasion, Barry. If I'm not mistaken, some 800 delegates who have registered. That is a tremendous achievement and shows the value of being able to have access to a digital platform that's worked exceedingly well. Thank you to the sponsors. You have kindly summarized their contributions previously. Meetings such as this are not possible without that kind of generous, unrestricted support. And I know that the Society, and certainly all of us that have participated, are very grateful to those sponsors. It is, of course, marvelous that you've been able to keep the meeting going during the pandemic, but I am heartened by your earlier comments that we might once again be able to come together in Johannesburg next year for the traditional end of October meeting. That's not to say that this hasn't been hugely successful, but the one great thing beyond the excellent content and the educational value of the South African Society meeting is the very convivial and friendly way, fellowship, that allows colleagues to come together to share experiences, to reinforce their deep commitment to patients, to reinforce their deep commitment to the highest standards of clinical practice, whilst being in a position to benefit from the educational opportunity. And that is achieved so powerfully through the physical meeting that we have annually in Johannesburg. But I think carrying forward the opportunity for a hybrid meeting to extend the reach of this programme as broadly as possible to as many clinicians and healthcare professionals as possible. So thank you all for your commitment today, and I'm going to hand back to our president.
Well, nothing more to say, but thank you, AJ, for your very kind words. And we hope to see you all next year, either physically, face-to-face, or in a hybrid meeting. And once again, I want to echo, thank you all the speakers, thank you the sponsors, and very much thank you the participants. Thank you. Have a good rest of your Sunday.